Hi, I'm Valerie Press. I'm going to be the moderator for the session today. I'd like to welcome you to the American Thoracic Society 2020 virtual session in partnership with the Science and Innovation webinar series. Today, we're going to hear two talks on the topic of use of big data in translational research. As mentioned, I will be the moderator. I am a physician researcher at the University of Chicago, and we'll be hearing from two incredible speakers today, Dr. Phil Verhoef and Dr. Matt Cherpek, and I will be telling you a little bit more about them ahead of each of their talks. We do also want to let you know of an upcoming webinar. So this will be occurring on Tuesday, August 18th. And it'll be the role of cytokines in lung cancer progression. So if you're interested in this, please also register for this opportunity. And as many of you hopefully know, there is going to be the ATS 2020 virtual conference. This will run August 5th through the 10th, and the registration will be opening soon. Finally, all of these webinars through the SIC will be archived and you can access them using this code. Finally, of course, we want feedback. So if you would be kind enough to fill out this SIC survey using the QR code here, we would love your feedback. At this time, I would like to introduce our first speaker. So I'm going to stop my screen share and introduce Dr. Phil Verhoef. He is a MedPeds intensivist working at Kaiser Permanente in Hawaii, where he serves as the Associate Program Director for the Kaiser Permanente Hawaii Internal Medicine Residency Program. He received his MD and PhD degrees from Case Western Reserve University, and then he completed his MedPeds residency at UCLA and his MICU and PICU training at the University of Chicago. Following the completion of his fellowship, he joined the faculty at the University of Chicago, where he was awarded in K08 to study the protective effects of the type 2 allergic immune response during sepsis using mouse models, human samples, and big data. He used those big data health records to do these analyses that we'll be hearing more about today. He recently relocated to Hawaii in 2019 to be close to family and is continuing his research using the electronic health record to understand the host response to infection. We'd love to hear your talk. Thanks, Dr. Verhoef.
All right, thank you, Dr. Press. I appreciate it. So it's a little earlier here than it is probably for most of you, but thanks for joining us today. So we're going to be talking about big data and translational research. I have no financial relationships to discuss. And so I think because this is a talk about translational research, we ought to define what translational research is. And I'm not going to spend much time on this, but many of you have probably seen this schema before, sort of the T0 to T4 stages of translational research, where T0 is very, very much basic science. T1 is starting to get into patient care, and then all the way up into global health. And so this was sort of the paradigm before. It's really moved now much more towards a patient-centered approach to translational research, where all of these different elements are sort of surrounding the patient, where the patient is at the core of this. And ultimately, to me, translational research is research that is specifically intended to improve the health of individuals as well as the public more broadly. And it really can have any number of different methods and approaches. And so, and what is big data? One definition of big data is that it's defined by the 3 V's: volume, variety, and velocity. Volume, it's big, right? Gigabytes, terabytes, petabytes, enormous amounts of data, which therefore requires sort of higher level processing and storage approaches. Variety, there are lots of different sources of data, both structured and unstructured. And then velocity, it's produced really, really fast and also needs to be processed very quickly. And so when you talk about big data in biomedical research, I think you can kind of put it into 2 big buckets. The first, on the left side of the screen there, is all of the omics that are out there, right? Whether it's genomics, which, you could argue that DNA is the ultimate original big data, right? An amazingly complex, intricate, and huge set of codes for our genes, all the way up to metabolomics, proteomics, even exposomics, the sum of all of the things they're exposed to, and how that relates to health and disease. And that's, I think, one big bin. And I think the other big bin is everything that lives in what we call the electronic health record, whether it's physician notes, whether it's insurance, coding and billing, vital signs, laboratory data. That's both structured and unstructured data. And so ultimately, this is big data. Now, we're going to be talking about big data and translational research. And so I will be talking about the use of big data sort of in that more T0, T1 framework. And Matt's going to talk a little bit more and a little bit closer to the T2, T3 framework. And so we've got a picture here of the big data pool. Come on in. The water is nice. So we're going to be starting with transcriptomics. And I picked this as an approach because most of us remember that DNA goes on to form RNA, and mRNA, just a second, honey, you need to go inside and find mommy to help you out if you need help, okay? Honey, you're gonna need to, that's fine, you can deal with it. Sorry about that. So so we're gonna start with transcriptomics because I think all of us remember that mRNA goes on to make protein. And so ultimately transcriptomics is focused on analyzing the thousands of different transcripts that are developed from our genome. And so you can either analyze that by sequencing it directly or by hybridizing to chips and looking at all of those expressed nucleic acids. And so when you're looking at it from a translational research standpoint, perhaps the most obvious way to do it is to compare the expressed mRNAs in two populations to figure out what is differentially expressed. And I love the story of Septicite. So Septicite was a commercial product that was developed several years ago based on this study in 2015. And so this group compared the RNA from the whole blood of 74 septic patients and compared it to 31 controls. And those were patients that had non-infectious inflammation. And the idea here is, let's try and figure out what's different about somebody that specifically has an infection compared to somebody that's inflamed but is not infected. And the idea is maybe we can develop a quick method to say for sure, hey, this person's infected, we need to give them antibiotics, we need to treat them a specific way, and maybe not give antibiotics to the non-infected person. And so out of the 30,000 different transcripts for these more than 100 people, so obviously they generated literally millions of data points, they identified four unique transcripts that could reliably discriminate between infected and not infected. And the names of them don't really matter for this paper, but those are all 4 gene transcripts that are either higher or lower in septic patients. And then they developed a score out of that they called the septic score, and then validated that in a new cohort. And ultimately, this worked really well. You can see with an AUC of 0.95 that they did a really good job of being able to discriminate infected people from non-infected people. And this has clear clinical relevance. And so this is an example of taking transcriptomic big data and turning it into a product to help clinicians. And I think that this is really fascinating. But to me, as a basic scientist, I really like the idea that transcriptomics could also identify novel transcripts to help us understand why these things happen. And the thing that I love about this story is that right about at exactly the same time as that McHugh paper, another group did pretty much the same experiment. They compared RNA from the whole blood of 74 septic people and 30 controls. But in this case, they were correlating those mRNA transcripts with the SOFA score and the likelihood of mortality. Now, if you're not a clinician out there, the SOFA score stands for Sequential Organ Failure Assessment. The higher your score, the more organs are failing for you. And obviously that's a bad thing. And we know that mortality is also a bad thing too. And so this group took a bunch of people and tried to correlate among those that were infected a relationship between a specific transcript and a SOFA score. And so this is just an example of some of their data. Now I look at this and I'm particularly struck by this square over here. Now, if you're an immunologist, you've heard of GATA3 because GATA3 is the master regulator of type 2 or allergic immune development. Without this transcription factor, you don't get allergies. And yet what they're finding in this particular study is that the more GATA3 you have, the lower your SOFA score and the less likely you are to die. So I think about that to myself and I say, that's interesting. A gene, a transcript that's up during allergic inflammation is associated potentially with a better outcome from, a terrible disease, right? So just to quickly review a little bit about immunology, we typically bin the immune response into two broad categories, either the type 1, which you see on the left there, and the type 2 on the right. And the type 1 is really your pro-inflammatory army, right? That's your neutrophils, your inflammatory macrophages getting out there, ingesting bacteria, ingesting viruses, creating the inflammatory response that we know of as sepsis. But that type 2 response on the right, that evolved to help us combat worm infections, helminth infections, and it's comprised of a different cell set, eosinophils and Th2 cells, and a different kind of macrophage. And normally, when we're living our world, these two exist in homeostasis. Type 1 can actually suppress type 2, type 2 can suppress type 1, but mostly you want a really nice balance between those two immune responses. And when you have too much of one or the other, that's where problems happen. So too much of a type 1 immune response, that's where you get things like autoimmune diseases like multiple sclerosis or metabolic disorders, potentially something like ulcerative colitis or type 1 diabetes. And if you have too much of a type 2 immune response, you're going to end up with allergic diseases or fibrotic diseases. And so if we conceptualize the immune response as balanced between type 1 and type 2, the hypothesis that really drove my K08 was the real problem in sepsis is an imbalance between type 1 and type 2 immunity, so that, rather than just thinking of it as, we've got too much inflammation and that's why you die, really we need to temper that response with the type 2 immune response. And so as I'm thinking about this hypothesis, I sort of say to myself, all right, if I'm going to make the argument that allergic immunity is better for people that are septic, this might actually mean that people with allergies do better when they get infections. And that seems like something of a heretical idea. Now, I'll spare you the mouse and the patient data that I have to support this idea. But the question that I had going into this was, how could I use big data to test this hypothesis? And I brought this question to Julian Solway, who was one of my mentors at the University of Chicago when I was there. And he said, why don't we look in hospital claims records? And so we took this data set that he had access to called the Market Scan data set. It has 150 million unique encounters in it. So this is based on insurance billing. And this is obviously an incredibly large data set, which has all of the diagnosis codes that were used for people to get billed for their for the healthcare that they received. And he said, why don't we look in here and identify all the patients with sepsis and then match them to patients that don't have sepsis within this data set. And we typically do this 5 to 1. And we'll match them to make sure they're similar in age and comorbidities and gender and wherever they get their treatment. And then let's look at the prevalence of immunologic diseases among these groups, because the idea might be that if allergic immune diseases or type 2 immune diseases are good, there might be fewer of them among the septic patients because they help keep you from moving on to develop sepsis. And conversely, if some of these type 1 inflammatory diseases are bad, you might find them overrepresented among septic patients. And then obviously we can compare that to the prevalence among non-septic patients. And so that's exactly what we did. And this is some work that we published about 3 years ago in the Red Journal. And you can see, this is just males, but the female data look pretty similar. We have two columns here, septic and non-septic, matched 5 to 1, so about 180,000 non-septic and 36,000 septic. And one of the first things we were struck by is the people that were more likely to have a disease in the septic population are down here, and that's folks with ulcerative colitis, multiple sclerosis, type 1 diabetes. The percentages are given right here, and those patients are more likely to have those diseases compared to people that are not septic. And we can calculate odds ratios and p-values. And You look at those p-values, I don't even know what to do with numbers that are that small, right? 10 to the minus 50, like that's crazy. For me as a basic scientist, I say, gosh, I guess that is significant, right? When you're talking about data sets that have thousands and thousands and thousands of people in them, you can potentially get some pretty wild results. So this was somewhat reassuring. We said, all right, there's more of these inflammatory diseases among our septic patients, but even more strikingly, there were fewer of the allergic diseases. So let's just look at allergic rhinitis, hay fever. About 11% of our septic patients had hay fever, 20% of the non-septic patients had hay fever. And so that is really a striking difference. And obviously, you know, what I'm seduced by is, gosh, maybe it's because of their type 2-ness, their allergic nature, that they are less likely to be admitted for sepsis. Now, there are, you know, plenty of weaknesses in this data. You know, we didn't identify all the septic patients in this data set by any stretch. We weren't able to control for medications. You know, obviously we use corticosteroids for, you know, both of these disease processes actually, potentially, but that could clearly confound our interpretation of the data. And we didn't do the opposite analysis, which was, instead of starting with septic and non-septic patients, why don't we start with people that have an immune disease and see how their hospital course goes when they get an infection? And so that was the next step of sort of big data work that I wanted to take on. And I did this in collaboration with Dr. Čerpek. And we looked at admissions to the University of Chicago over a 9-year stretch. And there were about 150,000 admissions during that period. We limited it to people that came through the ER with a possible infection and narrowed it down to about 11,000 people. And as you might expect, about 1/4 of them had an allergic disease or a type 2 immune disease, and about 3/4 didn't have that disease. And so I won't go through all of the sort of similarities and differences between the groups, but they were actually comparably sick based on their SOFA scores. And they had pretty similar vital signs and laboratory values upon admission to the hospital. But what we were really struck by was this. And this is a Kaplan-Meier survival curve for patients with allergic diseases and patients without. You can see that the folks that had allergic diseases, when they were admitted to the hospital for infection, were much less likely to die. And again, we were very sort of heartened by this because it's certainly consistent with my idea that allergic immunity is beneficial in the setting of acute infection. And we tried to do a little dose response, right? If you have more allergic diseases, do you get more protection? And it certainly looks like you do based on this. And then we did some propensity matching and logistic regression to try and narrow this down and control for some of these potential confounders. And even when adjusting for demographic factors, how sick you are, steroids that you receive, the types of infection, that same result held true, that people with allergic diseases or type 2 immune diseases were much less likely to die in the hospital, which was a really fascinating way for me to use a mechanistic hypothesis that I had as a basic scientist, allergic immunity, protective, and then to use two very different large electronic health record data sets to corroborate this in patients suffering from sepsis and infections. And so this is one approach to using big data in this kind of translational research, but what about taking a slightly different approach where instead we use the massive amount of data that's already there to generate some novel hypotheses about the immune mechanisms in sepsis or for subphenotyping. And so I'm going to just spend the last couple of minutes talking a little bit about temperature trajectories. And this is work that was done by an excellent pulmonary and critical care fellow, Siva Bhavani, who Matt and I co-mentored. And ultimately, he was using that same University of Chicago data set of hospitalized patients for infection, but instead, he was looking at temperature. And you say, well, why would he look at temperature? Well, it gets measured on everybody really, really frequently. So we have a ton of temperature data for hospitalized patients. Presumably your temperature reflects the immune response since, of course, it's these cytokines that mediate the development of a fever. And there's a lot of conflicting literature about whether or not fever is kind of good or bad. Is it something we don't want to treat, or is a fever a marker that you're going to do poorly? Is it going to mean that you're going to do well? And so Siva sort of took it upon himself to say, why don't we look at all of the temperature data and then see if patients with infections do differently as a function of that temperature data. And so his hypothesis was really testing, does temperature trajectory predict outcome among hospitalized patients with infections? And so what he effectively did, and this is work that we published in the Blue Journal last year, was he applied what's called group-based trajectory modeling to the first 72 hours of temperature data. And so he took everybody's data for those first 72 hours. And for some people that are in the ICU, they're getting, temperatures measured every hour or every 4 hours, or every 8 hours. It very much depends on the ward that you're on. And took all of that data and used this algorithm to say, are there these sort of natural clusters? Do some people all have the same trajectory with their temperature over those first 72 hours? And ultimately, he tried this a few different ways and was best able to classify patients into 4 groups. And I show them here, where the patients that we termed hyperthermic slow resolvers were up here in the yellow. And those were patients that were admitted to the hospital, warm, febrile, hyperthermic, and kind of stayed that way for most of the hospitalization. Compared to the hyperthermic fast resolvers in green, they came to the hospital equally hyperthermic, but defervesced within 24 hours. And then the folks that were red were normothermic, and they basically never mounted a fever. And then the folks in blue were hypothermic. These are people that came in cold. Not only did they not have a fever, they actually were, really met the criteria for hypothermia. And you say, oh, but Phil, this is not really febrile. You have to remember that these are data that are sort of, this is the best fit model for all of the data that we had. So some people were 39, some people were 37.5, but ultimately what we're doing is using all of that data to try and best fit people into a group that reflects well their temperature trajectory. And so, of course, now that we've classified people, how does that result in their outcomes? And so I think the most important one is that they have very different mortalities in the hospital. The hypothermic patients did the worst with a nearly 10% mortality. And those folks in green, the hyperthermic fast resolvers, did the best. So they resolved their fever, their inflammation quickly, and had a great outcome. And that makes you think, gosh, what are all the different reasons that could be? Well, these folks that are hypothermic are also older. We know about immune senescence, and that's the immune system, not working as well when you get older. Or maybe it's because they got more steroids, right? We know that steroids might suppress the immune response. And it could be any number of different factors, but mostly what was great was this is potentially a window into what their immune response is actually doing. And of course, we validated this in another data set and it held up. And so the final thing I'll discuss is some work we have under review. We actually wanted to see, does this actually reflect the biology? So can we take samples from patients and actually measure their cytokines and determine the cytokine profile of a temperature trajectory? And so working with Bhakti Patel and Krista Wolf and JP Kress, we collected samples from 120 patients with septic shock at 24 and 48 hours, and we measured their cytokines and classified them into one of the 4 groups. And so to see that pictorially, you can see that, they fit largely well into the same trajectories, but now we're measuring cytokines at these 2 different points to see how that reflects the immune system. And just to remind you, in this current study that we're talking about, again, the hypothermics, really high mortality, 42, 43%. Same for the hyperthermic slow resolvers in yellow, whereas the folks in green had the best mortality. And so just to give you a taste of this, we see really different cytokine profiles between these groups, where, again, it's the hyperthermic fast resolvers in green, slow resolvers in yellow, normothermics in pink, and the hypothermics in blue. These people that are hypothermic are not mounting any cytokine response, as you might expect from their temperatures. And that's, I think, really striking. And these folks that have the best outcomes in green have higher levels of certain cytokines. And I think that it starts to give us a clue to explain this different sort of subphenotype that we see. And if we look at the second time point at 48 hours, even more information here. What's the problem? Well, maybe the problem for folks in this hyperthermic fast slow resolver group here, these folks are dying a lot. Maybe it's because their MCSF levels are staying high or their IL-15 levels are staying high. But I think the real point here is we've taken the big data, we've identified a signal that lives in there, and then we've tried to come back to the bench and come up with the biology that underlies that. And potentially these are all going to be targets for manipulation, whether it's to augment or to block these cytokines. And so, you know, I think we've done a bit, sort of a bench to bedside approach using big data to show that allergic immune diseases or type 2 diseases are associated with protection during infection. But we've also taken this commonly measured data temperature to subphenotype folks, and then taking it back to biology to look at the cytokines that may underlie those different temperature subphenotypes and try and get a sense at how we can use this to personalize their therapies. So that's what I've got. These are a lot of the people that have worked hard on this particular project, and I'm happy to take questions now before Matt gets rolling.
Wonderful. And I really appreciate that. It was a wonderful talk. So we are having some questions come in through the chat. If you didn't see my note to you, please do ask your questions in chat. We'll be looking at them there. We'll spend about 5 minutes answering questions now, and then we'll move on to Dr. Terpek's talk. So there's one from someone named Brian. He asked, can you comment on how you're approaching data missingness? I imagine less of an issue for temperature with routine collection, but probably tougher for entries of past medical history, such as your first study. And those reasons, those missing entries may bias results.
Yeah, no, I think that's an incredibly good point. And particularly when you're looking at hospitalized patients, you know, you don't actually know necessarily what they're getting in the outpatient world. You don't know if all of the diseases that they have are actually making it into the inpatient medical record. And so, you know, we tried to handle this a number of different ways. You know, one was to limit the analysis only to people for whom we had both outpatient and inpatient data. At least that way, we would sort of assume that they're getting all of their care within our hospital system and that there's some crossover between at least some of those diagnoses. But, you know, I think, you know, another issue is really with medications. You know, we know exactly what they get on the inpatient side, but gosh, what are they getting on the outpatient side and how is that impacting? And I think that's an incredibly good point. You know, as we develop bigger and bigger data sets, like for instance, in the Chicagoland area, we have the Capricorn data set, which has both inpatient and outpatient data, or to the extent that, you know, I now work for Kaiser Permanente, where it's an integrated health system with inpatient and outpatient data, you know, seamlessly aligned. These are opportunities to do a better job of accounting for that. But I think that's a really important point that you have to think about when you're looking at some of this kind of clinical data.
Thanks, Phil. There's another question from Joe. For the cytokine level and temperature trajectory data, how do the causative organisms compare between the groups?
Really good question. I would have to go back and look. You have to remember that when people have septic shock, up to a third, a half, you don't actually know what the causative organism is. And we treat them empirically with, you know, gram-negative, gram-positive based on their risk factors or where the site of infection is. But in many cases, we actually don't know where, you know, what the causative organism is. And so some of the future work that we're, you know, thinking about is, can you start to bin based on at least gram-positive versus gram-negative, where you assume that your gram-negatives are going to bring in endotoxin-mediated, you know, higher fevers, different kind of inflammatory response than you get with gram-positives. And that's certainly some of the work that we're looking at. But at least for this septic shock cohort, it's kind of across the map, and we don't have enough patients in it right now to sort of say with any statistical certainty that that the specific cause of infection matters. When we did that with some of the other work that we've done, you know, you can look at the ICD-9 or ICD-10 codes for the infection that people are billing for, but again, that's imperfect. That's not biologically based. It's based on clinician judgment, and again, sometimes we just don't know what the causative organisms are.
Thanks. We have 2 more questions and then we'll have to move on to the next talk. And I know some people were entering comments. So 2 things. One, Phil did post his email in the chat. So if you don't get your question answered or want to follow up with your suggestions, you can reach out to him. And 2, again, this webinar will be available. So the final 2 questions are, one, how were the phenotypes in the temperature study developed a priori? And the second question is what sort of backgrounds do team members on the projects have apart from being clinicians? Like, are they computer scientists?
Yeah, so I think I'll take the second one first. So, I am not a computer scientist. I learned how to do some basic statistical programming in Stata, and that's really been helpful. So I was able to learn to do that analysis, but I did that guided by Matt Čerpek's group. So Matt has a PhD and knows how to do all of this statistics and programming, and he also has people that work with him that manage the data. And so this doesn't work without a collaborative approach where I sort of can bring the basic science of immunology in, and Matt brings the expertise in dealing with these kinds of data sets and the approaches. And then we work with people that, both understand what these diseases are, but understand how to manipulate the data, the strengths and limitations. And so anybody that's sort of interested in doing this, reach out and don't feel like you have to learn it all yourself. I certainly couldn't have done this without the help of lots of other people. And there are many people out there that have these kinds of chops. Now, in terms of the subphenotypes being defined a priori, the idea there was we let the model, the group-based trajectory algorithm, take the data and figure out what are the best numbers of subphenotypes that we could identify. What are the best number of trajectories? So, one of the things we found is if we tried 5 different groupings, we ended up with one of the groups not having very many patients, such as to, us to lose statistical power for making any kind of inferences there. And so, we didn't actually know going into it that it was going to be some people are hyperthermic and stay hot, some get cold, some are hypothermic. We actually didn't have any idea. And it was very much what the data told us the subphenotypes were going to look like. And then we sort of went from there to sort of validate it in other big data sets and validate it in some of the samples that we had.
Wonderful, thank you. And I know some more questions have come in. If we have time at the end, we'll get to them, or else reach out to Dr. Verhoef. Now I would love to introduce Dr. Matthew Čerpek. He is a board-certified clinical informaticist and physician scientist whose research program focuses on developing and implementing prediction models to detect early clinical deterioration, acute kidney disease, and sepsis, so as to improve patient outcomes. Dr. Čerpek has an MPH from the University of North Carolina at Chapel Hill and a PhD from the University of Chicago. His research has been supported by a KO8 from NHLBI, an ATS Foundation Recognition Award for Early Career Investigators, and an R01 from NIGMS. Dr. Čerpek is an ATS Fellow and received the American Thoracic Society Assembly on Critical Care Early Career Achievement Award in 2019. So thrilled to have you, Dr. Čerpek.
Great. Thank you very much for the invitation to speak at this very exciting, interesting event. And thanks to the ATS for having me. And can everyone see you can see my screen, Dr. Press?
Yes.
Okay, excellent. All right, so I'm going to move on from talking about using big data for epidemiological analyses and cluster analyses to what we call supervised learning, where we actually are trying to predict a specific event. So I'm going to focus on clinical deterioration. So these are my disclosures, including the research funding that was mentioned. We have research funding also from EarlySense, which I'm not going to talk about today. And we also have a patent pending for risk stratification algorithms, which I will be discussing today. So first, I'm going to talk about why should we be risk stratifying patients who come to the hospital in the first place. I'm then going to talk about what the current state of risk stratification is in the hospital. In other words, who's sick in the hospital, who's not sick, and how can we determine an individual patient's risk. I'm then going to go on to discuss how you can use patient-level data to develop prediction algorithms. And then finally, I'm going to talk about the implementation of these risk stratification algorithms in real time in hospitals. So first, why should we be risk stratifying patients who are admitted to the hospital? Well, first, if you take your average patient comes to the hospital, so the patient, they're not in the intensive care unit yet, they're on a general medical surgical ward. Many of these patients actually do quite well and they're discharged home or to wherever they were before the hospital. But unfortunately, some percentage of those patients, about 5%, in many hospitals will experience clinical deterioration. This deterioration can lead to the patient needing to go to the intensive care unit. They can also suffer a cardiac arrest where they lose their pulse and someone comes in and does CPR and they may also die. So the idea of risk stratification is really, can we figure out which patients are going to develop clinical deterioration, because maybe early intervention could improve their outcomes. So it turns out that if you look at cases of in-hospital cardiac arrest, which again are defined by loss of a palpable pulse, and then you go in and do CPR or try to resuscitate them, they actually occur outside the ICU. So there's over 290,000 cases of cardiac arrest each year in the United States. And over half of those that occur in the hospital actually occur outside the intensive care unit. There's been decades and decades of research on how we should improve the care for these patients. For example, what songs should you be listening to, like Staying Alive, when you're doing CPR, due to the right chest compression frequency. But unfortunately, survival remains very poor for these patients. And there's several lines of evidence suggesting that we may even be able to prevent these events from happening in the first place. For example, if you look at vital sign abnormalities in the hours before cardiac arrest, in the 0 to 8 hours, you can see about half of patients have vital sign abnormalities, which is not too surprising. However, if you look at 8 to 48 hours prior to the event, still about half of patients have vital sign abnormalities. This suggests that for many patients, these are not sudden deterioration events. We may be able to identify these patients early so we can actually potentially prevent the event from happening in the first place. If you look at cardiac arrest causes, there are conditions such as sepsis, respiratory failure, cardiac ischemia, conditions where we know that early intervention can improve outcomes. Furthermore, if you look at what happens around the time of the arrest, there are many medical errors that unfortunately happen. For example, the study by Hodgetts et al. Looked at, based on manual chart review, the errors that occurred, and they found that things like delays in diagnoses and errors in diagnoses were very common. And the resident house officer is often the most senior physician in almost half of the cases. So if we can improve risk stratification of patients in the hospital, we can potentially get critical care expertise to the bedside of the patients who need them the most. In addition, I mentioned that deterioration could also mean having a patient go from the ward to the ICU. But unfortunately, those patients are often transferred too late. They often languish on the wards for many hours. And we and others have found that each hour of delay of getting a critically ill patient into an ICU is associated with increased morbidity and mortality. So early identification and risk stratification could get these patients to the ICU sooner, which could improve their outcomes. Finally, some high-risk patients, goals of care discussions are going to be an important intervention. And in fact, if you look at this study where they looked at the deaths in their hospitals prior to when a rapid response team, an RRT, was in place in their hospital versus after the rapid response team was in place. And these rapid response teams were multidisciplinary teams of clinicians who go to the bedside and try to figure out what to do for these patients. They actually found that by implementing a system for identification and treatment of critical illness, they found that more deaths that occurred in their hospital died under comfort care with decreased pain scores and decreased subjective suffering. So by risk stratifying patients and identifying high-risk patients early, not only can we potentially prevent some events from happening, we can also improve the quality of the end of life as well. So these ideas and others have led to the proliferation of these rapid response teams, these multidisciplinary teams of clinicians that help identify and treat the highest risk patients on the wards in the hospital. This has been essentially mandated through the Joint Commission and also throughout many countries around the world, including Australia and the UK. So then with this in mind, how are we currently risk stratifying patients in the hospital? Well, it's typically done a lot like this, although maybe our hair is not quite so perfect on morning rounds. But it's a bunch of clinicians standing around a patient saying, maybe I think this patient is good enough to potentially go home in the next day or two. Or maybe this patient is deteriorating and I think maybe they should be seen by the critical care consult service to potentially go to the ICU. But it's typically based on subjective opinion across different providers. And we know that based on their level of experience and level of comfort caring for critically ill patients, that sometimes patients unfortunately fall through the cracks. However, this has then led groups to develop more objective tools. For example, this is the Modified Early Warning Score, or MUSE, which is the most common risk stratification tool that's used in academic hospitals today in the United States. And you can see that it's essentially based on a bunch of different vital signs, and then abnormalities of those vital signs then lead you to add up a final MUSE score. And if a patient has a score above a certain value, you would call the rapid response team or call the primary team for that patient. However, these scores are based on subjective opinion in individual hospitals. And in fact, varying opinion has led to over 100 different variations. Many of those are actually called the Muse or something very similar. So when you're in an individual hospital trying to decide what tool to implement in your hospital, it's sort of like this kid where you ask him to go and buy you a drink. There's so many different options, and it really does matter which one you choose. In fact, if you look at some prior work, you can see that these scores have a wide range in accuracy. For example, this is a study done by Smith and colleagues where they looked at the sensitivity for death across a wide range of scores, and you can see that the score sensitivity ranges quite a bit. So it really does matter which tool you actually implement in your hospital. And poor accuracy results in an ineffective rapid response team, because if you can't actually identify the patient who's deteriorating, you're not going to get the rapid response team to the bedside, and therefore your whole system breaks down. In fact, if you look at the different studies investigating the impact of rapid response teams on mortality, you actually find quite a variety of different odds ratios and effect sizes. And that is likely, at least in part, due to differences between the interventions, including how you're actually identifying these patients in the first place. So what we wanted to do then as a group was to actually use patient-level data to develop prediction algorithms and then to implement these in practice. So how did we actually develop these algorithms? Well, what we wanted to do was to develop an accurate risk score for adverse events, deterioration, using EHR data. And we used the same definitions that I mentioned earlier. We utilized a large multi-center database funded by a CTSA grant. And then we ended up with a large multi-center cohort of 5 hospitals, including the University of Chicago, as well as 4 North Shore hospitals. And we had quite a mix of the different types of hospitals, which we feel would improve the generalizability of our tool. We want to develop a simple score that could be used in any hospital. So in other words, not using things that aren't commonly collected. And so you can see that we use predictive variables like age, vital signs, and commonly collected labs in the model in order to increase its generalizability. We then wanted to compare a number of different machine learning algorithms. So in medicine, what we typically do is to take a logistic regression model. We put all our variables in as linear predictors so we can get those nice odds ratios, and then we essentially use that for the modeling. However, the machine learning as a field has developed many, many different algorithms that one could use for developing supervised learning models to predict different outcomes. And so we wanted to compare how these different algorithms would perform in this data set. So our final study population was almost 270,000 admissions with over 400 arrests, 13,000 ICU transfers, and almost 3,000 deaths that occurred on the wards. When we looked at all the different predictor variables that we put into the model, it turned out that respiratory rate was actually the most accurate predictor. So even though it might feel like it's always 18 or 20 in your hospital, when it's not 18 or 20, when it's 23, 25, when it looks like they're actually counting and it's a high or sometimes a very low number, your risk actually goes up quite a bit. In addition, other vital signs were also good predictors, and then age was a good predictor, as well as measures of renal function were the best laboratory predictors. In AVPU there, as you can see, is a mental status variable. So we looked at the different methods, the machine learning methods. What we did find was that the more modern machine learning algorithms actually did much, much better than logistic regression. So these are areas under the curve. So 0.5 is a coin flip, 1 is a perfect score. So you can see that the random forest, which is a more modern machine learning algorithm, was much more accurate than logistic regression with linear terms. But all of these were much more accurate than the Muse, and it had higher discrimination for predicting clinical deterioration in our data. So what are random forests? If you look at the medical literature, these are being used more and more often in data, not only EHR data, but also in genomics data and other fields as well. So random forests are based on these simple decision trees where you take your data and look for the best splits of each variable to see how you can actually develop these individual trees that will predict your outcome. For example, again, here for this example tree, you can see that respiratory rate greater than 20 best splits the cohort into people who are going to have the outcome versus not, and followed by age is the next best split. And essentially at the end of this tree, you then get a prediction for the outcome. Random forests are essentially a combination of hundreds and sometimes thousands of these individual trees that are combined together in an ensemble to make predictions. And these random forests are much more accurate than the individual decision trees themselves. Now you can also visualize these, similar to getting odds ratios from a logistic regression model. You can actually see what are the most important variables in the model. For example, here is similar to the earlier individual variable list, we found that respiratory rate was the most important predictor. You can also look at individual variables and see what the relationship is between the risk and the risk across values of the variable and the outcome. And just like you would expect clinically, your risk for deterioration is very high when either you're not breathing or you're breathing very fast. And essentially, once you go above 20, your risk increases quite a bit. So just like you'd imagine if you were a clinician thinking through this. In addition, you can look at this through age. And unfortunately, we found that no matter how you model it, turning 40 really is bad news. And then what we wanted to do after looking at these methods is we wanted to see, well, what about these more advanced methods that are really making the headlines over the last few years, like deep learning? So deep learning is based on these neural networks that really can learn just about any pattern out there. And in fact, it's what you use in many voice recognition software and computer vision, facial recognition software and others. It's really been the revolutionary breakthrough in machine learning in terms of how it's impacted the private sector. So we wanted to essentially take this technology and see if we could use it for patient data. Now, patient data, a lot of it is not in picture form. And so what we did was we essentially took a patient's longitudinal values of their data. And here you can see along the x-axis is time, and along the y-axis you can see the different variables. And they essentially get normalized, and you essentially trick these methods into thinking that it's looking at a picture, when in fact it's really just looking at a trajectory of a patient. What we did was we separated data into derivation and validation cohorts, and we compared machine learning methods based on deep learning to things like the Muse and the SOFA score. What we found was that deep learning models, again looking at AUC, were much, much more accurate. Essentially using the first 48 hours of data, you can predict mortality in the hospital with an AUC of 0.91, and those deaths were happening an average of about a week after admission. So you can actually predict quite accurately, pretty far out for death in the hospital, much better than the other tools that are available. You can also highlight what parts of the model and of the individual patient's trajectories are actually most important for that prediction. So finally, I want to talk about real-time risk stratification in action. How can we actually implement these models in action? And so we first ran a silent study of our score, which we're calling ECART, which is the logistic regression version of the model I talked about earlier. We wanted to test the feasibility of calculation as well as compare it to current practice. So in a period of a little over a year on a medicine and 2 hem-onc units, we compared the accuracy and timing of our score alerts compared to what the rapid response team was doing for the outcomes I mentioned earlier. We a priori categorized patients into high, moderate, and low risk, and we calculated the score, but in this study, we did not use it to implement any intervention. So the clinicians at the bedside were not able to see the score. We were essentially doing this as a black box study to see how well it would have done. What we found was if you look at the standard practice, unfortunately, the rapid response team is only seeing 10% of the cardiac arrests and only about a third of the ICU transfers. However, our ECART score at the high-risk threshold would have detected 80% of the cardiac arrests and half of the ICU transfers. And that intermediate risk would actually have been able to see all of the cardiac arrest patients and over 2/3 of the ICU transfers. So really a significant improvement in the detection rate based on our algorithm. I'm just going to skip past this just in the interest of time, but just to make the point that we actually were also detecting these patients 31 hours in advance. So not only are we detecting many more patients, but we're also detecting them about 30 hours before the event, as opposed to the rapid response team, which is only seeing the patients about an hour before the event. So we've now implemented this score live. We're running live in almost 20 hospitals now. And in this, for the high-risk patients, you get an automatic rapid response team call in many of the hospitals. Intermediate risk patients, you're getting proactive rounding. So the rapid response team will see the intermediate risk patients in between seeing the highest risk patients. And for the low risk patients, we're continuing present care. And in fact, for some of those, in some of the hospitals are starting clinical studies, we're actually letting some of those patients sleep, because in fact, patients actually like to sleep in the hospital when they can. We've developed a user interface where we can actually see not only each patient in the hospitals from sickest to least sick, but you can also look at individual trajectories over time. and you can see what are the variables that are actually driving the score. In addition, we also created clinical pathways where you're assessing the patient, you're screening them for sepsis, you're screening them for how concerned you are, and then you're providing actions like reassessment in 2 hours, continuing present management, calling the primary team or the rapid response team, or ordering a lactate. So we've now developed an algorithm, we've implemented it in practice, and we have structured way of how we're actually implementing it at the bedside. Our utilization rate is quite high. So for the highest risk patients, utilization rates are over 90%. So oftentimes you can develop a tool, but no one is actually using it. But we actually have found that the people are really using this with really high implementation rates, especially for the highest risk patients. This implementation has decreased cardiac arrest. So we've actually, if you look at University of Chicago from prior to compared to after eCard implementation, we've actually significantly decreased cardiac arrests with over 50% reduction in rate since 2014. In the North Shore hospitals I mentioned earlier, we also decreased mortality. So this is a paper that's soon to be under review, where you can see we decreased mortality from a pre-period compared to a post-period, even after adjustments for differences in characteristics. You can see a significant decrease in mortality with the number needed to treat to prevent 1 death of 20 patients, which is pretty good. So overall, I think that really the future of clinical medicine is going to be not the exhausted clinician in the middle of the night getting pages and trying to say, hey, what should I do? And maybe I don't even know this patient very well. But it's actually be the clinician plus an algorithm that can help identify which patients should we be sending the rapid response team to, or maybe be going to see quicker than these other patients. It's also going to help the bedside team help their own decision making. And finally, also helping with quality review in terms of becoming a learning health system where we can continue to improve these systems themselves to make them better, so we have no longer have patients slipping through the cracks. So I think the future is really going to be a combination and partnership between clinicians and algorithms in order to make us have more effective and more efficient care. I really want to thank all our collaborators at many of the different sites, and thank you all for your attention. And my email is at the bottom of the slide in case anyone has questions. I'm very happy to reach out and talk to anyone. So thank you all for your attention.
Thank you, Dr. Čerpek. That was another wonderful talk. So we'll take questions again via chat. I'll be monitoring for those. And as you can see, the email is there if we don't get to any of your questions or you have some offline. So we have a question from Carrie. This question is coming from a lower resource setting. Apart from integrating these machine learning developed models into electronic health records, do you think, hold on one second, my chat moved. Do you think that mobile apps could be developed to apply machine learning models like the traditional scoring systems such as the PASHI-2 for use by clinicians?
Yeah, so that's a great question. So I would say that absolutely. I think different groups are using different methods to implement these tools, whether you're just using, for example, some of the groups in Australia are making it part of their paper records. So as you're charting your paper records and putting in the vital signs, if you, for example, put in a 30 for respiratory rate, that will go into, you actually put that physically in a red box because of the value. And depending on how you're charting, you actually, that charting itself will drive implementations. And so I think that that's something that, whether we're talking direct integration in the EHR or mobile apps or even paper solutions, there are going to be different ways that you want to personalize which tools you're using and then how you implement the tool in your actual workflow. Because the most important thing is to actually implement it in your workflow in a way that you can use it and make it easy for everyone.
Great. Thank you. That's great. And there was another question that came in. Are there useful methods to approach generalizing the algorithms to institutions other than where the data were derived from? So for example, with respiratory rate charting practices, you did mention some of this just a minute ago, may differ across. So if a nurse is worried about a patient in order to have an accurate respiratory rate, et cetera. So are there useful methods to approach generalizing algorithms to other sites?
Yeah, so I would say there are many different approaches. I just want to speak to 3. So the first one would be, if you have enough data in your own health system and you have the expertise, you could always develop your own model. One of the challenges there is if you don't have enough data, if you don't have the expertise, or if there are other ways to leverage what other groups have done, you may find them to be much either more cost effective or just more feasible to use models developed by other groups. And so then I think the next step probably is to see if those models are working well in your institution, because sometimes you'll be surprised that they actually work really well. Maybe the cutoff you use at one hospital might be different than the other one, but the overall discrimination of the model may be similar. If you actually if you find that your model doesn't work well in your new setting, I think there's a couple different approaches. Probably the most well-known one in the machine learning world is something called transfer learning. So essentially what you do is if you imagine like a neural network or another model where you have sort of a number of different layers to that model where you have all these different coefficients that are kind of layered on top of each other. What transfer learning does is you learn in one setting, and then maybe you freeze a bunch of those layers or coefficients, and then you transfer that to a new setting where you may not have as much data available. And you can then allow the model only to learn a few of the coefficients while you keep all the other ones frozen. So transfer learning is a common approach that people will use in a setting where you have lots of data in one setting and only a small amount of data in a new setting, and you want to essentially transfer what you've learned in model 1 to setting 1 to setting 2. And that would be another option. It only works for certain types of models, but it is something that you should consider doing.
Great, thank you. There's another question. Is the algorithm fixed or continues to identify patterns with machine learning?
Yeah, so that's a great question. Right. So one option would be to create a model and then you implement it. And then once you implement it, you don't change your model. The other approach would be to run the model. And then once you implement it, continue to figure out like what patients are still dying or we're still missing after the fact. This is an undetermined answer, which was best. My main theoretical concern for updating your model after you implemented it is the patients who still have an event after you implemented it could be the non-preventable events. And so if you start tuning your model and learning toward those patients, you may go from detecting preventable events and improving outcomes to then detecting non-preventable events, which I think it's pretty clear that there are some of these that just aren't preventable. And so if you do that, it's possible that your algorithm could get better for newer patients, but actually could do worse overall in terms of improving outcomes. So I think you always need to consider what is the impact of, what are you gaining, what are you losing by changing your model after you've actually clinically implemented it? Because I think you need to really do that with a lot of caution.
Thank you. That was excellent. Those were the primary questions that came through. There was additionally some comments that some folks were having, thanking you for your answers and other things like that. So I think given that we're so close to the end of the hour that we'll just review a couple of things. So I again want to thank very much the American Thoracic Society and the SIC for hosting this webinar, to our speakers, Dr. Verhoef and Dr. Čerpek, for such great presentations and answering your very good questions. And then I do want to just remind everyone, if you would be so kind as to complete the SurveyMonkey feedback tool here that's listed in the chat. We would love for you to take these final few minutes just to complete that before we have to sign off. So again, I think both Dr. Čerpek and Dr. Verhoef have offered to continue any answers to questions you may have offline. They provided their emails. If you didn't capture it while they were shared in the chat or via the webinar screen share, we will just reach out to us at the ATS and we'll be able to get you that information. Please do join us on August 18th for the next upcoming webinar that was mentioned at the beginning of the talk. More emails will be coming out about that, and you can also find the information on the website under the SIC page. We are about 1 minute till the end of the hour, so I'll just give another thank you to everyone, and then we'll just leave this chat up for a moment for you to complete your survey. Thanks, everyone. Have a good day.
Great. Thanks, everyone.
Thanks. Bye-bye.